Morning, everybody. My name is Alan Lucerna. As you know, I'm one of the attendings at Stratford Kennedy University Hospital. Today we're going to be talking about geriatric neurologic emergencies. Pretty hefty topic. It's pretty broad, but this is pretty much entailed towards what you would see in an elderly or patients now are coming in designed for a specific type of ER where there's a lot more focus towards geriatric medicine. So this lecture was actually done through support by the Reynolds Foundation. Before we do the lecture, we're going to do a couple of tests and see what our prior knowledge is to this topic. So which of these tests is not part of the stroke evaluation in the emergency department? Everybody answered A. Very good, guys. When evaluating for potential thrombolysis, which of these criteria is an absolute contraindication for recombinant TPA administration in a patient who is in a 3-hour window? You guys put your answers? Very good. So anybody who has got some form of coagulopathy, whether it's an INR greater than 1.7 or platelet count less than 100,000, there's an absolute contraindication to administration of TPA. So everybody seems to have done a good job. According to the recent published trials on the use of RTPA in patients presenting in a 3 to 4.5 hour window, age above 80 is a contraindication. Put in your answers. So the answer is A. If you even look at the data that they're saying, even on your neuro toolkit, there is a little snippet in there that says this has not been tested in somebody over 80. We do it, but the recommendations is as a contraindication. Okay, so today we're going to be talking about trauma, strokes, which is a prototypical neurovascular emergency in the elderly, subarachnoid, a little bit of subdural hematoma, dizziness, one of the most common things in the ER, and infectious causes. So when it comes to geriatric trauma, the overall incidence is about close to 400 cases in 100 persons in the US. And the incidence in the elderly shows that it pretty much peaks around 85. As you can see, because of changes in our eyesight and the way we coordinate things, and with comorbidities, medications, people as they get older accumulate all these things, and collectively it affects the way they move around. There's a predominance for females, and subdural hematoma is the far more common presentation in the elderly as opposed to the young. So as you can see there is like 46% of all traumatic brain injuries in the elderly and 28% in the young. And for some reason, epidural hematoma is actually less common. Elderly also is more prone to pedestrian accidents and falls. The incidence of falls in somebody who's older than 65 is about 30%. And that goes up to 50% in patients who are considered octogenarians. This is, like I said, it could be secondary to our normal aging process, our superimposed disease, medications that we take, medicines for blood pressure that produces orthostasis, diabetes that produces neuropathy. So these are the things that make the elderly more prone to falls. So we get this a lot in the emergency department. Oh, there's this lady from the nursing home who was walking. She fell from standing position. You know, she didn't lose consciousness. She's awake. She's confused at baseline, or sometimes they're like, you know, nobody knows what their baseline is. They just come to the hospital, and you have this 80-year-old lady who's very cute. She's got a little bit of a laceration in the head that does not require any kind of repair. What do you guys think are the things that come to mind whenever somebody falls from a standing position or same level fall? I mean, what are the chances of anything that's bad that could happen from somebody who was fallen? I mean, things that you would entertain before you go into the room. Anybody? What's that? I mean, like, is somebody comes in from nursing home, they had fallen, you're about to go in, and the triage note just says, this lady was walking, she tripped, she fell, she didn't lose consciousness, she's got a small laceration. Okay, fracture. Okay, medication, very good. What are you looking for? Okay, very good. Now we have also now a problem with Pradaxa. So those are the things that you want to think about. But how about like in terms of injury? What are the chances of them getting a cervical fracture from a standing height? Or what are the chances of them having an issue with bleeding or fractures of the skull? This is not an elderly person that jumped, did a somersault, landed. Some face plant? Okay. Very good. Anybody else? So we got central cord issues. How about fractures or anything like that of the cervical spine? Are they more prone to it? Are they not more prone to it? Okay. So there's somebody there that you might not be able to clear them clinically. Okay. So this is the case in Stratford. Lady was just walking. She came out of the room and said, "I think I fell." But the nurses prior to that, 2 seconds before that, heard a thud. They all rushed in, and she already is at the door. She's has a, what kind of injury is that? What's that? Okay. So pretty extensive bleeding. This is a lady also fell from a nursing home also. No neurodeficits, just a little bit of a headache. That's a subarachnoid in the posterior section of the Sylvan fissure. Now these people come in also and they never complain of any pain. Eric Maddock had a patient that went to room 11, status post fall from standing height. She actually tried to get up from the chair and didn't really quite make it standing, fell backwards. And that's the story we got, at least. But when she went to room 11, she's walking, talking. She didn't lose consciousness. Sent for a regular CT of the head, CT of the C-spine, and there is actually a C2 fracture. But they never had any pain or neurodeficits, So as a personal story, my wife's grandmother, nobody could reach her for 8 hours, and somebody went into the room, to the house. The neighbor went to the house, found her on the floor. So took her to the hospital. Didn't have any pain. So we rushed to Pioli. Went there. She was in a C collar, and she's like, "Hon, I don't know what they did. All I needed was a turkey sandwich, and this thing is so tight." And she's moving her head like this. There's a type 2 odontoid fracture with no pain. Nothing. The nurses actually would find her taking off her collar at night. She would go to the bathroom, come back, and of course, everybody was getting very, very upset and frustrated. But she did very well. But this is just to tell you that the magnitude of the injury may not be what it seemed at first from somebody who just falls from a height, a single level fall. So when compared to young patients, elderly are 7 times more prone to injury, so about 48% compared to 7% in the young. And they're actually more prone to have fatal falls. There's 30% chance of injury in the elderly. It's mainly a lot of head and neck injuries. And these low falls are, mortality rate from these could approach 15%. So the amount of elderly population is going to be in the realm of, I think, predominantly by the year 2050, and looking at that number, that's going to be close to, I guess, my age when that arrives. I'm going to be in the 60s. So spinal injuries in the elderly is really different because it's typically in somebody who's young, the most flexible segment is about C4, C7. As we get older, there's some degenerative diseases that affect the spine, making the upper cervical spine more mobile, and this predisposes them to injury. So the most injured part is usually the upper cervical spine, particularly the odontoid. In one study, a small number of patients, C2 injuries account for about 40% of the fractures. And typically, it may also involve C5, C6 in about 12%. But in multi-level fall and multi-level injuries, it involves C1 and 2 and 5 and 6. And a lot of times we're kind of like faced with a situation where they look great, they don't have any issues. The question a lot of times is like, why don't we do a cervical? Are we doing a cervical spine CT scan as opposed to just plain films? A lot of these patients have pre-existing issues with their joints in the neck, the disc space may be arthritic, so it's very hard to read them on a plain film. And you could miss a lot of things there if there is superimposed arthritic issues. So therefore, the threshold for immobilization and a high, I guess, advanced imaging is more indicated. Patients are also more prone to pedestrian injuries. I mean, sometimes they cross the street and they don't look and they get run over by cars. There was a lady that came in about 2-3 months ago, was at Walmart, and the car backed into her, ran over her foot. She actually had a pelvic fracture. We transferred her to Cooper Hospital. But a lot of these people don't want any kind of pain medication. I mean, she's got a broken foot, she's got a pelvic fracture. You say, hey, can I offer you some pain medicine? She's like, no, I'm going to be okay. I just don't want to move, and I'll just sit here and try to minimize my movement. And you almost compelled to basically force them to take the medication because when you take them to imaging studies, they're going to have some sort of pain. But a lot of the elderly, as you would have guessed, do much better if they were transferred to a trauma center. The survival benefit is tremendous, 56% versus 8%. These particular group of patients, however, are less likely to be transferred. They're probably 60% of them gets transferred as opposed to 82% if somebody is young. Mortality rate for these patients, especially if they have a traumatic brain injury, is about 30%. And age, as you would guess, remains an independent risk factor for death, even if everything else were equalized. Their outcome to discharge is very poor as well, and especially with cognitive and functional outcomes. So we're shifting gears to stroke. When we say about neurological emergencies, stroke probably is the prototypical type of thing that come into mind when people talk about emergencies dealing with neurovascular or cerebrovascular issues. So, this is a quick triage, I guess, decision rule or screening tool that the EMS use. Is there any kind of facial asymmetry? Is there any kind of motor deficit or sensory deficit in the arms? Is there a particular change in speech? And the most important thing is, when did it occur? So those are the first thing that you basically ask when they arrive in the ER. So there's close to about 800,000 patients in the United States that have new or recurrent stroke, and that's a tremendous number. A good majority of these, about close to 80%, are ischemic, and by 2025, this is approaching 1 million. And in 2003, about 200,000 died from stroke, and it's basically the third leading cause of death after heart disease in the US. It's number 2 in the world. there was a study done called the Copenhagen Stroke Study, and basically there are some things that are associated with a very poor functional outcome, and these are people who are over or equal to 85 years old, being female, having atrial fibrillation, and pre-existing disability. And these are the things that portend a very bad outcome. So as you could see there, in close to 48 months, 36 patients are alive as opposed to 477 in somebody who's younger. Greater than 85 where the line has a broken line. So the tremendous discrepancy in terms of survival benefit. So this is not just a US issue. This is more of a global issue, and as the world becoming more like a global economy, it's going to impact more as the years progress. As you can see there, every nation that's pretty much placed there, stroke is pretty much an issue. Even in Australia, where people are actually more active, in UK, Ukraine, as we age, the chances of getting a stroke is so much higher. So in terms of pathophysiology, the brain is about 2% of the body's mass, but it basically gets about 20% of our cardiac output to basically use for metabolism. And the disruption of this flow is pretty much what the definition of a stroke is. Now, seconds to minutes after there is a disruption in the blood flow, there's loss of glucose and oxygen delivery, and a cascade starts. And the cytokine gets released, there's edema, and cell death ensues. So what we do basically when we treat patients that come in for stroke is that we are actually trying to save the penumbra. Where these are the zones that have decreased flow of blood, however, they're still viable. The one that the core of the stroke is pretty much done, so there's not much that we can do about it. So we talked about earlier that 80% of strokes are ischemic. They could be embolic in nature, it could be thrombotic, it could be lacunar, or watershed regions. So when we say stroke, it could be the intrinsic blood vessels of the brain gets clogged. It could be an embolus. It could be decreased perfusion, whether it's from sepsis physiology or from shock. It could be an increased viscosity, secondary to sickle cell disease, or it could be a rupture of blood vessels. So those are things that causes these strokes. So in the United States, it's one of the leading causes of disability. About 25% or 26% of stroke survivors need some sort of assistance in daily living. 30% need some type of assistance walking. 26% requires admission to long-term care. And not only do they have any kind of physical issues, they also have psychiatric problems as well, secondary to the stroke. The cost is pretty much, it's tremendous. Everybody's talking about the fiscal cliff, and there's no money in the world that's left. Stroke will contribute to that as the aging population grows. There's close to pretty much 70 billion per year, and that's in 2009 cost. So in stroke eval, a lot of you guys are very good in screening. So it starts with EMS, and detection is the first, pretty much the first thing that needs to be done. EMS gets dispatched, they get a screening process, they arrive in the ER, and hopefully they have all the information that you need in terms of like time of onset. So there are a couple of pre-hospital assessment here, the Cincinnati pre-hospital stroke scale, the Los Angeles pre-hospital stroke scale. There's also some question whether should I take a patient with a stroke just to the closest hospital, or they do better in a place where it's a designated stroke center. And as you guys know, Kennedy is a designated stroke center now, and our numbers in terms of outcomes are actually very good. I remember I think last year we won like a silver award for from the American Stroke Society. So You have a case of a 77-year-old female that comes to the ER with right-sided weakness, dysarthria. She was doing her laundry. She noticed that the right arm is not moving. That's the vital signs, and the NIH score is 16. I mean, there's no question that there is some sort of neurological issue here, right? So the first single most important piece of historical information is what? What's that? Time of onset. And why are we harping on this? If you look in here, so every 60 seconds of ischemia leads to about 1.9 million neuron loss. So as you can see there, somebody who is first stroke, 1.2 billion, synapses, 8.3 trillion. Accelerated aging, somebody who's got a stroke, it pretty much accelerated by 36 years. If it's per hour, it's like 3.6 years per minute time. You can see it's tremendous loss of neurons, and these are very, very sensitive to metabolic changes in the brain as well as blood flow. If a stroke runs for a full course, about 10 hours, you would have lost 1.2 billion neurons, 8.3 trillion synapses, and about 4,000 miles of myelinated fibers. That's pretty tremendous data. So sudden weakness in the face, arms, or legs, you know, these are things that you already know. Time of onset, is it resolving? These are things that you need to know because these plays a role, it plays a role in your thrombolytics and when to call for neurology. So this is just kind of like a talk about location. So if it's anterior portion, anterior cerebellar artery, there's a question of motor and sensory deficits. A foot greater than the face, you might have the frontal lobe syndromes. You know, they go back to the grasping and sucking reflex. There's abulia. There's rigidity. There's a gait apraxia. If it's the MCA region, if it's the dominant side, you will have aphasia, some motor and sensory deficits, more so in the face and the arms than leg and foot. If it's the internal capsule, you might have hemiplegia and some homonymous hemianopsia. If it's the non-dominant hemisphere, you will have neglect. You have motor and sensory deficits, more so in the face, leg, and foot. And if it is in the posterior circulation, you'll have some visual symptoms, some alexia, visual hallucinations, and some visual perseverations. You might have some movement disorders, chorioathetosis, some sort of pain syndrome. More of the so penetrating blood vessels in the middle cerebral artery could produce a pure motor hemiparesis. That's more lacunar type, or pure sensory motor. There may be some ataxia, some dysarthria, some clumsy hands. In the posterior circulation, if it's vertebrovascular, you could have some cranial nerve palsy, some cross deficits, double vision. They could have dysphagia, they won't walk, or if it's close to the reticular activating system, they may have coma. If it's internal carotid, they could have a progressive or a stuttering type, especially the MCA syndrome. And occasionally, the anterior cerebral artery may be inadequate to provide collateral flow as well. A lot of question, does stroke give you a headache? And the answer is yes. It can give you a small amount of patients with ischemic stroke can have a headache. So, but majority of these are all from bleeding. So this is the NIH score that you guys are familiar with. Everybody basically runs through whenever a patient comes in. And as you can see there, as you get older, the NIH score gets higher. Your percent of favorable outcome, which is on the right side there, is worse. So without belaboring this, the emergency room assessment, as you guys already know, you get your ABCs, you make sure you check an Acute check. Nothing like having to thrombolize a hypoglycemic episode or somebody's having a seizure. These are some of the stroke algorithms that we have. A lot of times, if we have to do a thrombolysis, don't forget to order a type and screen. So the Kennedy system, if you order the stroke alert panel, the typing screen is there. Because after you thrombolize someone, you're not supposed to draw any more blood. So just get everything out of the way. Pretty much the same thing that we talked about, just a summary. So you identify possibility of stroke. EMS gets notified. Hospital assessment and stabilization. You activate the stroke team. The patient goes to the CT scanner. Is there a hemorrhage? If there's none, you basically run through your algorithm for exclusion and make sure that they are not on any kind of anticoagulants. It's very important. Okay. If it's a candidate, we have teleneurology. Speak to neurology, have them evaluate at the bedside. You go ahead and you give the TPA and run the protocol after that. If there's no hemorrhage and they're not a candidate for any kind of TPA, you give antiplatelet therapy. You could also give Lipitor. If there is a hemorrhage, ship the patient out immediately. And of course, if they are staying in the hospital, you begin your stroke pathway. So a lot of times, by the time the patient gets back to the ER, the CT scan report is usually not available yet. And in our system, we activate the neurology consult. Most of the time, we look at our own films, and what we're looking for is pretty much to exclude any kind of bleeding. But at times, we're pretty lucky where we're able to see the early signs of stroke. And some of these signs, the most obvious is the dense MCA sign. Okay, but these are the things that could actually come out as well. Obscuration of the lentiform nucleus. To tell you the truth, I would never be able to pick that up. Okay, there's insular ribbon sign. I'll show you these are signs of early stroke that you will see. And a lot of the neuroradiologists are attuned to this, and they'll be able to pick things up. So this is a guy, and I think Horgan probably uploaded this on our website. This gentleman was actually talking to his nephew, and all of a sudden he said, "Oh, my grandpa became confused," and he kept on repeating things that he was saying. He came to the ER. He's looking to the right side. He's got normal speech pattern. He's basically not moving the whole entire left side. He cannot move his eye past the midline to the left. So he's got a pretty dense deficit. Went to CT scanner. We called the teleneuro, and the neurologist was driving. So she said, "Can you call the neurosurgeon and talk about, to talk about the patient?" So of course, called the neurosurgeon, and he's like, "Well, give TPA, time his brain. Go run into the room, run through a checklist of exclusion criteria," and the patient's like, "I don't want that stuff." Family is, initially they were all crying, and like, "Grandpa, take the medication." And we said that, with this particular type of blockage, I mean, you could see that big clot burden in there, right? TPA alone is probably not going to do anything. He's a high-risk patient for mortality. I mean, I think a lot of these patients that are not treated has an 80% mortality. So we tried to convince the family to convince the patient to receive TPA. And the patient is like, no, I don't want any of that stuff. If I die, I die. And in the same sentence, he's like, "I want to live." So you're like running on a clock here, because the good thing, he came in within the hour. He got all the CT scans, neuro consult within the hour. The problem is the neurologist is not able to see the CT scanner. So here you are, pretty much your sphincter's pretty tight because the clock is ticking. And by the time neurologist gets on the teleneuro and the robot, it's like 2 hours. So she looks at the CT scan, and we scroll down. After she sees this, she's like, "Oh, I got to go see the patient." She goes to the room, sees the patient, begs the patient to receive TPA, and the patient's like, "I don't want that stuff." So she's like, "Okay, sir, where's your right arm?" So the patient's like, "Here it is." "Where's your left arm?" "Opposite my right arm." Like, that's what he says. So the question a lot of times, if the patient does not want TPA and he's got a severe neglect, does he have the right to refuse? Or can you pretty much argue that if the large stroke is occurring, he has no capacity to make decisions. I mean, what do you do with that? You know, and here you are, had to make decision to transfer the patient after you TPA because time is running out and he's got a large infarct. And, you know, what are you going to do? So eventually the family decided to make the decision for the patient. We get TPA, he got shipped out. By the time he got to Washington Township, he completed a stroke. There's pretty much nothing that can be done. So he actually had a little bit of bleeding surrounding the area. But you can see the changes here from day one, this 16 hours later, 21 hours later. You can see the loss there of gray-white differentiation. Completion of the stroke. It's a midline shift. So for the most part, dense MCA sign is something that you will be able to say and hopefully be able to catch, because these patients, even though you give TPA, the chances of them having a recanalization is still very small, especially if the size is about 8 millimeters. They will need some sort of mechanical retraction or mechanical device to remove the large clot burden. In some literature, they even talk about a high-density internal carotid artery sign, or high CAS. And it's pretty much a similar thing. A good about 10% of patients with dense MCA sign will have the dense internal carotid artery sign as well. So TPA is level 1 care as instructed, I guess, but as recommended by American Heart Association. There's a lot of controversial issues, and there's two sides to the fence and a lot of these things, but at least here where we practice, it's standard of care. So they have to present within 4.5 hours of symptoms. You have to exclude bleeding, and you have to review a contraindication and make sure you document that you talked to the family, you talked to the patient about the risk and benefit, the bleeding. Contraindications will be talked about, bleeding, surgery, and these are things that you could look up. A lot of the stroke protocols and a lot of stroke centers have a written paper somewhere for exclusion criteria, especially if they have any form of like coagulopathy, INR 1.7. Make sure you don't forget to ask about Pradaxa stroke scale. So there's a new study that just came out. I think it came out in May. It's called the IST3. And pretty much in the prior studies, the majority of patients that are greater than 80 years old were not in great numbers. So there's some question whether you know, it will work in somebody who's 80. Have we seen patients who are 90 years old and get lysed all the time? I mean, we see patients at Lourdes who get lysed, 91 years old. In our institution, 92 years old gets lytic therapy. But make sure you talk to neurology, which pretty much in our institution is pretty much by default. But you know, nobody has really have a good literature to support whether this thing works in the elderly or not. So IST3, when it came out in May, the data is really controversial because in some snippets of it, the words that they use is trend towards benefit, trend towards harm. I mean, there's no compelling thing that says it works really well in somebody who's 80 years old or not. There's one section in there that says it has trend towards benefit in 1 to 3 hours, but 3 hours to 4.5 trend towards harm. Greater than 6 hours may trend towards benefit. So what do you do if you're at a 3-hour period? You wait till 4.5 hour passes and then give the TPA. There's a lot of like controversial issues. Like I said, I mean, if you look online, a lot of editorial stuff. The results basically is that this is not a blinded test, unblinded. I mean, this is not unblinded test. It's a everybody pretty much know what people were getting. But the benefit basically is 37% have favorable outcomes at 6 months. And the people that did not get a TPA, 35% had favorable outcomes. So statistically, it's really not a lot of difference. So the expansion time, initially it was up to 3 hours. Now it got moved to 4.5 hours, was due to ECAS 3. And the exclusion a lot of time is the 80-year-old. And if you look up, some of you guys have apps actually that says, what are the exclusion criteria at the bedside, and you can still see there that there's the 80-year-old exclusion criteria. So pretty much automatic after you give the TPA. Make sure that hemodynamically they're optimal. Monitor the blood pressure, maintain at 180/110. And prior to dosing TPA, make sure that their blood pressure is not greater than 180/110. And there's a lot of protocols in our ICU to pretty much avoid hypotension, hypothermia, and make sure that after they have a TPA, you monitor for signs of bleeding. How about those people we think had a stroke, but they didn't really have a stroke? It's very hard to evaluate sometimes, especially if they came from nursing home. We're not really sure about, and they had prior strokes. With one case in Stratford, came in with left upper arm weakness. So initially, the triage paper from the nursing home says it started today. It started like 2 hours prior arrival. The patient had a history of stroke. So I think the attending called the family. There was no family available. Called the nursing home, spoke to the nurse. The nurse was new to the patient and said that, the patient is not able to move the left arm. So anyways, went through the protocol. The neurologist says TPA. Give the TPA. Patient at the time was actually transferred to Cherry Hill because there was no room in the ICU in Stratford. Family visits in Cherry Hill and says, he had a stroke about 10 years ago. He's always got weakness on the left arm. And this has not changed. And of course, the attending over at Cherry Hill called over to Stratford, told the attending to give TPA, and he had cold equina symptoms afterwards. I'm talking about the attending, not the patient. So he's like, nobody told me. Anyways, hypoglycemia must be ruled out first. That's why you do the Acute check. If there is family members, make sure you utilize them in terms of historical information. The EMS, make sure that they don't have a history of malignancy, that this may be occurring. Make sure that you know the history of drug use. There's a lot of patients in our population here that may be 60 to 70, but they still do cocaine and other drugs. Anyways, if, for example, God forbid, you were convinced it is a stroke, but it was not, and you give TPA, some studies have shown that these patients actually do very well and they don't have a high risk of bleeding. And that's because their vascular system is pretty intact and there's no issues in terms of hemorrhage or edema. And there's no, a lot of the studies shows that they're not prone to bleeds. So what do you do when patients that you gave TPA to basically bleed? You discontinue TPA, monitor for, herniation, get a surgical consult, and if you can reverse, try to reverse the bleeding. There's not really that you can do other than supportive care. So medical consideration, if you work somewhere where you're pretty much the ICU, the med-surg floor, the telemetry, and the ER, or you board patients, hopefully you won't have to, but make sure their oxygenation is adequate, fever control, blood sugar control, and make sure if it's a bleeding type, they get seizure control as well. Control the blood pressure, and monitor for decompensation. Talked about oxygenation. There's a propensity in all of us that if the patient comes in, even though their oxygenation is probably 94%, 95% to put oxygen. And there's new studies now, especially when it comes to post-arrest resuscitation and heart attacks, that giving oxygen may be actually bad because you produce all those radical oxygen species that we talked about when you were a first-year medical student, and it's come around full circle now, and they may come the way of the stroke. So if somebody comes in with adequate oxygenation, is there really utility in putting oxygen? Everyone so far that I've seen, though, whether here or Cooper Hospital, they place everybody on oxygen. But I think it's more reflex than anything. Temperature control is very important. Blood sugar. So when we say blood sugar control, the recommendations by the American Stroke Society is basically treatment if it's greater than 140. But you also have to be cautious that any type of hypoglycemia has a tremendous insult in a brain that's just starting to heal. So some recommendations were to give treatment if it's above 180. We talked about this earlier. Seizure control. Pretty much in ischemic stroke, there is no prophylactic anticonvulsant that's recommended. But if they do stroke, treat with benzo. So anticoagulant that is further down the line is not our decision. It's a decision basically in consult with neurology. These are more for people who have atrial fibrillation, and we're talking about here and patients that are TPA'd. So it's hopefully by the time that the patient gets shipped upstairs, it won't be your decision anymore. So there's positioning of the head. What is optimal? So some studies have been showing that if you decrease the head from about 30 to 15 degrees, there's an increased blood flow velocities, on average about 20%. However, patients also are prone to aspiration when you do this, so just put them about 30 to 15 degrees. Keep it neutral. There's some question whether if you turn them one way or the other, that they may occlude a pre-existing intercarotid issue. So these are some of the treatment that were speculated to work and improve patients' outcome in terms of stroke. None of these things have really panned out. Switching gears now to bleeding. Any questions anyway about stroke? Critiques or other anecdotal personal experiences? Okay, we'll go ahead to a spontaneous intracerebral hemorrhage. The incidence is about 10 to 20 cases per 100,000. And as we age, of course, we're more prone to bleeding spontaneously. Mortality is very high, some at times close to 50%. And pretty much the treatment is supportive care, stabilization in the ER, neuroconsult, ICP monitor if we have it, reverse the coagulopathy if they have it, and seizure prophylaxis. If they have showing of increased intracranial pressure, you could hyperventilate them in the vent. You give mannitol. This is a patient that Chris Pashadi and I saw in his last year. So this patient, for some reason, was on aspirin, Plavix, and Coumadin. And the history also says the patient has ataxia. This is unbelievable. So the patient tried to get up from the couch and from a rocking chair. This is like a setup for a movie. From a rocking chair, fell backwards, and didn't really see the family member right away. So she said she didn't lose consciousness. She helped herself. About 2-3 hours later, the daughter came home and basically said that the patient was not acting right. She had a fever. Didn't really tell the daughter that she fell. So she got brought in, and that's what showed up. So a few words on subdural. A lot of times, if it's a chronic form, this thing may be misdiagnosed. And these are people who are on anticoagulants. They may have fallen about 2 weeks ago, and now they come in complaining of a low headache. Family members may think that they're a little confused. So I think we don't have a problem doing a CT scan in our institution. So us missing the subdural may be low, but make sure that you don't forget, though, to entertain this differential when you have somebody who's got those issues where they're not acting right. So, and I think that might be the worst case triage note on there. What's worse than not acting right? And you get these cases sometimes, or like 80-year-old from nursing home not acting right. The worst case would be not acting right for 6 months. So why did they come to the ER at 3 a.m. in the morning? So less likely to be classical when they present. They get headaches, maybe some vomiting. So make sure that your gastroenteritis, you have to entertain that maybe central in origin. They could have seizures. They could have subtle cognitive deficits, some personality changes, memory loss. So make sure you evaluate for that. Now, this is not a subdural. What kind of bleeding is this? What is it? Okay. So this patient has a history of, it was a bipolar disorder. So he apparently has not been feeling well, didn't really complain of a headache, and has been sitting in a bathtub for like 2 days. So eventually the brother is like, why are you sitting in a bathtub? And I think the day before he had a fight with his brother, and the brother didn't, they live in the same house, didn't really talk to him. So just saw him in a bathtub. And the patient was like, I'm not feeling well. I sat in the tub and I feel a little bit better. So, and the brother was like, well, when I went to work today, did you ever leave the bathtub? And he's like, yeah, I got out of the bathtub and I went back again. Did not have a headache. I mean, I was telling the nurse, I'm like, yeah, this guy either had encephalopathy or something, or like, he's got some sort of bleeding. Because the blood pressure is like 225 over 120. So anyways, we sent him for a scan, and of course this comes back. And he's been sitting there for 2 days in a bathtub. And no headache, I'm telling you. So 78 out of 100,000 among the aged 70 to 88. So it's not very common. So average age and presentation is about 50 years old. That guy was actually 68. Advanced age, of course, is independent risk factors. Outcome in 3 months is about 25%, somebody who's over 70. If you were 40 years old, 73% good outcome. Rebleeding rates are very high. They're more likely to get vasospasm. A lot of times, too, I guess part of the reason why they don't do very well is that a lot of the older folks live by themselves, or they are left alone for a long period of time, and nobody has really, alerted the EMS system that there's something wrong. Sometimes they just found by their neighbors not acting right. As you can see there, I mean, there's a inverse relationship between mortality and age. And as you get older, mortality is actually I guess an inverse relationship, or I guess, I don't know what to say, what the relationship is. So of course, airway control. Some literature advocate for a MAP of 130. Some use systolic blood pressure of 140 or less. So medications that we use typically are nicardipine or labetalol. These are easier to titrate. Don't do any nitroprusside. I haven't seen that given, but in case of your institution later on, don't use it. It dilates the cerebrovasculature. It increases ICP, impairs autoregulation, and there could be excessive hypotension, which in subarachnoid hemorrhage is pretty bad. So our role is pretty much detection. So the CT scan is about 95% in detecting subarachnoid bleed in the first 6 hours. That 5% or so, we might have to augment by lumbar puncture. If your suspicion is very high, there's a strong family history, you could either talk to the surgeon, neurosurgeon, for a possible transfer, or possible, if you don't have an MRI in your institution, you have to really consider this. But if you do have an aneurysm, coiling it is much more superior to clipping in the elderly. So dizziness, very, very common presentation in the ER. A lot of times we just chuck it up to labyrinthitis or Meniere's or benign positional vertigo. Sometimes they don't mention it like that. Vicky and I had some patients that are kind of like the same thing, where this nebulous type of complaints. They could just be fatigued. They feel like they're almost passed out. Their balance is off. Sometimes you would get the classical explanation of, the room is spinning, which is very, it gives us so much more relief than all these other vague words. But they have some illusory sense of motion. So if it's peripheral, it could be sudden onset, it could be severe and associated with nausea and vomiting. It could be some hearing loss. Make sure you ask if they have ringing in the ears. It's pretty concerning in the elderly because our history and physical is not really that infallible. Sometimes we are having a hard time distinguishing between central and peripheral. There could be some overlap of symptoms. But infarction of the vestibular nuclei is really indistinguishable from neuritis. So one study that was done about 50 to 75 years old with an isolated vertigo, 25% has cerebellar ischemia. So if they have hypertension, diabetes, hyperlipidemia, they had a history of heart attack before, history of stroke, comes in with dizziness, they had a hard time walking, those are probably the ones that need to stay. Your battle's really not with the patient for the most part in terms of staying, but more so for the admitting doctor. Your institution that you may end up with later on, maybe one of those where admission criteria is pretty strict. But have a low threshold for admitting these patients or getting a neurological consultation and also doing an advanced imaging. So peripherally, they have some motion sickness. It could be secondary to benign positional vertigo, otitis media, vestibular neuritis, Meniere's, some meds, Lasix could cause some of this ototoxicity. It could be central vertigo. Just one other caveat. One of the patients came in. She's apparently not waking up. She has a history of end-stage renal disease. She is on dialysis. She's got a history of cabbage. Went to Stratford. The surgeon saw the patient. And it's like, oh man, I can't believe no family history. No family was present to say, hey, the patient was walking before or anything like that. So, but the nursing home said that she's typically walkie-talkie. So tried to wake the patient up. She's very somnolent. Of course, she's entertaining all this differential. And I don't know how he did it or why he did it, but he ordered an alcohol level. Alcohol was like 250. So he's like, he calls the family, and finally he gets a chance to speak to one. He's like, is there any access to alcohol? It's like, yeah, we can get some alcohol in the bar, and nobody ever thought of it. I actually forgot to ask him how he came up with just, I guess automatically he just by reflex ordered a coma panel and got an alcohol level of 250. But anyways, these are some of the causes of central vertigo. Central vertigo, of course, is an emergent treatment needed, but in terms of differentiating it, people with peripheral vertigo may have difficulty walking, but people with cerebral stroke, they can't walk at all. I remember one time, though, there was a case over in Cherry Hill of a young patient, I think 37 years old, who got sent home and came back and had Wallenberg syndrome. He had a posterior inferior cerebral artery that ruptured. So steroids may improve outcomes in patients that have vestibular neuritis. So a lot of these patients I actually give Decadron. Also put some transdermal scopolamine. If you give Antivert, especially if they go home, a lot of these episodes where they get dizziness occurs especially in the morning when they first wake up. So they don't really have the time to take that Antivert, and by the time they're probably vomiting. So to, I guess, give them like a steady supply of medication, transdermal scopolamine is one of the things I utilize. But you could also do some modified Epley Maneuver. Dr. Sexton, when I was a resident, tried to do this on one of the patients in the ER, the ones that he didn't really want to admit. He tried to do this, and the patient vomited on him. So make sure you try to do this away from you. So a lot of times, like, oh man, I'd love to discharge this patient after they get admitted. So this is just one pictorial tutorial on how to do it. Make sure away from you though when you do it. And lastly, let's talk about CNS infection. There is a bimodal peak in terms of meningitis, the young, the elderly, and these two, the elderly and the young, like infants, have a pretty much kind of like a similar presentation These complaints are very non-specific. It could just be confusion. They may have a blunted response, like fever response. They could be hypothermic. So, this is due to either their senescent type of immune response or the nutrition is not up to par. But there is a large spike that occurs in infants and older than 60 years old. The geriatric case is about like 10 cases per 100,000. It's very common that the diagnosis is delayed. However, if it's delayed, of course, there's implication in terms of prognosis. The classic triad of fever, nuchal rigidity, altered mental status is about 46% sensitive. So, I mean, it's good to do and put in a chart. If you do your legal rotation yet, they advise you to always put the words there, negative for Kernig's and Brzezinski, negative nuchal rigidity, no rashes that are petechial in nature. So those are the things that you look for, and as well as document. And more than 99% has at least one of the classical, triad. So fever is the most frequent one, but the absence of all three and ruling out the diagnosis is really is not very high. And nuchal rigidity in particular is not very helpful because about close to half of the elderly population have some sort of neck stiffness, but 50%, and that's due to either degenerative disc disease, but 35% also without the infection have some sort of stiff neck. And the rigidity could be from Parkinson's. 12% of healthy elderly will display a positive Kernig sign, and 18% will have Brzezinski. And about close to 60% of these patients who have meningitis actually also have other confounding infections. They may have pneumonia or UTI, so make sure you just think about the differential. But these are the most common organisms that are seen in the elderly or patients over 50. So listeria is one of the ones that is seen. Patients can also have epidural abscess, and the delay as well is occurring in up to 75% of the elderly. So a lot of these folks have pre-existing back issues, and 85% of them don't have the spinal pain, fever, and neurologic deficit. So make sure you look at the area, make sure they don't have any kind of cellulitic issues overlying it, make sure you didn't have a new surgical procedure, whether outpatient or not. They don't have any kind of ports that may alert you to seeding of the back, and have a low suspicion in patients who are having tremendous amount of pain. Epidural abscess is something that needs to be emergently transferred in our institution. This is after you provide antibiotics, of course. If they have cervical abscess, make sure that you intubate the patient. That pretty much sums it up. It's just an overview of a lot of emergencies in the elderly. Things that we probably should have included would have been like seizures or status epilepticus in the elderly. But any questions or comments? Ken?
The patient that you had before, about you had Christmas childhood and one you had with Jamie, where you lysed
Yeah.
and was kind of a little bit of delay.
Yes.
The day the patient didn't get better,
Yeah.
did they start anticoagulation afterwards before we saw the repeat CP bleeding?
They did not, because the mortality rate in these, afterwards is more supportive. Some people could, some institution advocate some sort of decompression by removing part of the skull. You saw the edema there, right? It's large.
Yeah, no, I mean, before we saw the bleeding and then later on, I mean, right after they were nice, they weren't getting any better, because I know some
Right.
people talked about when we started.
Yeah, it was not recommended. The size of the infarct, and a lot of times when you do, even after you lyse, it's contraindicated to give the heparin and all that stuff. But you really are not probably adding anything in terms of giving anticoagulant, because the size of that is really not amenable sometimes to thrombolysis. I think in terms of the MCA, the longer it is, but close to 8 millimeters, the recanalization rate, I think, is 25%. So a lot of these patients who have those large size MCA, will probably end up needing some sort of mechanical extraction.
Right, that was my next question.
Yeah.
Is that something that they considered or talked about?
He was transferred, as soon as he got the lytic therapy, the helicopter was right there, transferred in Washington Township. By the time they got there, they did a CT perfusion study, and based on the perfusion, it was a completed stroke. So they didn't go ahead and do it. But you have to be careful, though. There are entities that will mimic dense MCA sign. The vessel there is dense because of the clot burden, but there are some vasculitis and also infectious process that will mimic that. Temporal, like a herpes zoster encephalitis could actually make the surrounding area hypo-attenuated, making the MCA more pronounced. Also, some other hyperviscosity syndromes could also make that pronounced. So not everything that has a dense MCA sign is stroke. So any other questions, guys? Okay, thank you very much. Oh, Ken?
Actually, you said before about whether or not anyone had any interesting stories.
Mm-hmm.
I actually had a patient that I licensed with one of our alumni who graduated last year or two.
Mm-hmm.
The patient was the oldest patient I ever licensed. He was 92. She actually, for the record, did not do well. But a little bit of a teaching pearl. It was actually a syncope certification. Fell and it had significant MCA distribution stroke symptoms. And so we went and got the NCT right away. NCT was negative. It wasn't like blood thinners, I don't think it was any ABS. We talked to the family, actually got the teleneuro people involved, and they recommended lytics. So we kind of told the family, it's a pretty significant stroke. We're going to have probably a bad outcome any way you look at it. We said go ahead and do it. We didn't see anything else that normal on our workup. So we pushed the lytics, and then we basically shipped right over to the Capitol. And the patient was about 5 minutes down the road before they turned over and went to the Richmond Walton with a large, massive, massive hematoma in the chest wall, and clavicle fracture. So anytime you have anyone that has fall.
Yes, that's what I was going to tell you.
It's not just the head CT that you have to think about. Last I checked, clavicle fracture is not a contraindication of lytics. However, it looks pretty clumsy. Your colleagues may think a little less.
So, a lot of times when they have a syncopal episode as a presenting event, you always have to worry that there may be a traumatic issue somewhere else. Sometimes a lot of these syncopal episodes are not witnessed, and the elderly, when they fall, they might not remember what they hit. So, like you were saying, make sure you do a little exam. It's hard to tell sometimes. Yeah. The other thing, last week I had this lady that came in from the home, from her house. She came in basically leaning towards the right side, and when you talk to her, she seems like she's had 2 cups of coffee, kind of distracted, not really encephalopathic, and she's like, "Doc, my arm just keep on moving without any kind of I'm not doing anything. It moves. It's like this. It's like finger to nose, like that. All right. Grip is equal. Strength is equal. You do a pronator drift test, and she's like this. She's like that. It's like the legs. She's like oh my god. She's got cerebellar issues here. Cerebellar infarct. All right. So I called neurologist, and teleneuro actually is evaluating another patient. So she went for CT. CT came back normal. Looking at the cerebellum, it's like, is there a attenuation there or not? Just like a cerebellar incident. She gets on, and she was in the parking lot in the car. The teleneurologist. And she's like, okay, let me see the patient. I said I asked her about medications. We gave her some medicine for dystonia just to check and see if that reverses. She goes over. It's like, I don't think it's a stroke. It's probably not a stroke, but her testing pretty much the same thing. I said, man, if I seen her somewhere else, I would say she's got Huntington's disease. That looks like chorea to me. So she's like, yeah, it's choreiform maybe. I don't know if it's like, I was like, is it hemiballismus? And she started laughing. Just like, I wouldn't TPA her. I don't know what's going on. It's probably not stroke, but admit her to the ICU. She looked at the cerebellar section. She's like, yeah, there may be something in there, but it was red negative. So anyways, I looked at the dictation the following day because they sent the patient for an MRI. And there was actually an infarct in the frontal parietal. So I looked it up, and there are some choreiform type or hemiballismic movements with frontal parietal infarcts. So I'm like, oh man, I wasn't even looking at that. So anyways, so those are the things that, all right guys, thank you very much. You guys enjoy the rest of the day.